A patch in time saves 9. Ocular injury can be classified as closed globe or open globe. Corneal laceration and corneal perforation are common ocular trauma with potentially devastating sequelae, including corneal scarring, astigmatism, and endophthalmitis. Depending on the features of corneal injury, multiple approaches can be taken to repair the cornea. In case of small or self-sealed corneal perforation or corneal laceration, bandage contact lens can be used to promote epithelial healing. For smaller perforations, glue plus bandage contact lens, multi-layered amniotic membrane grafting, thin lens patch graft, or a corneal patch graft can also be planned depending upon the size of the perforation. For larger perforations, tectonic penetrating keratoplasty may be required. For corneal tears with loss of corneal tissue, suturing is effective against lacerations. But if partial corneal defects coexist, tight stitching of the wound is likely to result in decreased vision due to high irregular astigmatism. Repairing the lesion with the same sized corneal patch may help to re-establish the corneal structure and curvature. Indications for patch graft include infections, sterile melt, trauma with tissue loss. Irregularly shaped corneal laceration, especially those with partial corneal defects or perforation, often put ophthalmic doctors in a dilemma. Improper apposition of the wound edges or an influence on the corneal curvature might cause severe corneal scarring and high irregular astigmatism. We present a case of a 65-year-old farmer from Andhra Pradesh who presented with chief complaints of sudden loss of vision, pain and watering from the left eye since one day. He had history of penetrating ocular injury with a tree branch while working on the farm 1 day ago. On evaluation, his right eye had a visual acuity of 20/20 and an anterior-posterior segment evaluation was found to be normal. In the left eye, his visual acuity was hand movement. A full thickness cruciate tear near the limbus at 8 to 9 o'clock was noted with tissue loss. Iris was seen plugging the site of perforation. Anterior chamber was shallow with blood clots in the anterior chamber and a traumatic cataract with anterior lens capsule breach was noted. The B scan was suggestive of vitreous hemorrhage. A provisional diagnosis of left eye open globe injury type B zone 1 with tissue loss was made. Since it was a cruciate tear with round blunt margins with tissue loss and perforation of more than 3 mm, the apposition of the tear margin with extra tight sutures would have resulted in irregular astigmatism, distortion of the contour of the cornea, and poor visual outcome. Corneal patch graft was planned to repair the site of corneal perforation under general anesthesia. The left eye was cleaned and draped. The corneal tear with flap and tissue loss was noted. Peritomy was done. No scleral extent was noted. Prolapse of iris and lens matter along with vitreous was seen. The prolapsed iris tissue was abscissed and localized anterior vitrectomy was done to clear the vitreous at the site of the wound. The size of the defect was 4 mm. A 4 mm trephine was used to mark the area of the tissue loss. Edges of the tear were cut with vanas to create a round, well-defined edge. And the donor tissue was trephined with the trephine of size 4.5 mm and was secured to the host tissue with the 9-10-0 nylon sutures. On post-op day 1, the patient was doing well, graft was in place with 9 sutures, anterior chamber was well formed, phacodonesis was noted and the patient was started on prednisolone acetate, chloramphenicol, hometropine and chymotrypsin. On subsequent visit, the patient was doing well. A total traumatic cataract was noted with anterior lens capsule breach. At post-op 1 month, cataract surgery was planned to remove the cataractous lens along with anterior vitrectomy. After making the side port, the capsular excess was attempted, with cystitome but could not be completed because of zonular weakness. Scleral incision was made with blade, crescent and keratome, and rest of the rhexis was completed with microrhexis scissor and forceps. Nucleus was prolapsed and delivered with the vectus. Iris prolapse was noted through the main incision. The scleral incision was closed with 10-0 nylon sutures. Subsequently, the cortex was also washed. IOL implantation was deferred in view of irregular astigmatism induced by the sutures of the corneal patch graft. On post-op day 1, the patient was doing well. On subsequent visits, the best corrected visual acuity improved from hand movement to 20/160. To conclude, repair of the corneal perforation with tissue defects with corneal patch grafts minimizes irregular astigmatism, maximally restores the anatomical structure of the globe, preserves long-term corneal stability, and restores good visual function. Thank you.